how would you summarize the main differences between the old published guidelines and the new ones?
I think that's a very important question. Of course, many things are different. But I think the main concepts is that just the structure already. So we followed the ESGO guideline, the ESGO protocol for guidelines. Before it was within the INCIP, we had our system, and I think the ESGO system is much more professional, and it's so I think that's an added value of the new guideline. Secondly, I think patients' representatives were present. I think that's also a very important added value of the new guideline. And I think we spent more time on psychologists who were involved. So that's from conceptual point of view, that was already an important innovation or an added value of the new guideline. And of course, then in between there are many, I think we used extra experience and new scientific data that were incorporated. And actually it resulted in different flowcharts. So we cannot say that the flowchart that we used in 2019, we completely redesigned it based on the novel input. So from that point of view, it's really like an important update.
Thank you.
On my behalf also, Professor, really thank you for being here for this interview. And this is of course really important to summarize what are the major differences. I would like to go, let's say, step by step from the beginning and make a very simple, but I think a very fundamental question. And when actually we treat cases like that, cancer cases during pregnancy, what should be, based on the guidelines and also your experience, the optimal context of treatment regarding also facilities, hospital, physicians and so on, in order to treat ideally these cases?
Also, this is a very important question. I think it is too uncommon, too rare, that we can expect that all gynaes, all medical oncologists have this vast experience in this. So I think we need to look for people, teams that have sufficient experience. And so I think we need a center with sufficient volume. Also, a hospital that is large enough that allows you to have these oncologists, these surgeons, but also a good obstetrical team that is used to treat high-risk pregnancies. And you need a good neonatal intensive care unit, because we see that premature delivery is quite frequent and sometimes it is very preterm. So at least we need to have this infrastructure to treat and to have all the expertise. So basically it is related to volume. A hospital with a large volume is most likely to have all these expertises in-house.
Very well.
And I think so it's not wrong to refer a patient, and either for a complete treatment, or you can refer a patient to get an advice, and then depending on advice the patient can come back or should have all the treatment in the referral center. So that really is dependent from the case. But I think always an expert should be involved somewhere in the decision making.
Of course.
Thank you. And could you please tell us what is the frequency of cancer cases in pregnancy?
Overall, we think it's about 1 in 1,000, 1 in 2,000 pregnancies. For breast cancer, it's 1 in 3,000. So that are the general figures. We have to say also that it may differ a bit according to the age of women, so it might be different a bit from country to country, but the problem is that in countries you got an obstetrical registration and you got an oncological registration, but you don't have the cross between the two, so you don't have exact data on the outcomes. But based on Scandinavian figures, we estimated a bit like 1 in 1,000, 1 in 2,000. And then actually melanoma is actually the most common. In INCIP we register only cases, melanoma is not always registered. So we see in our clinic much more breast cancer, and this is also the cancer which is most common in that age population. But in fact, if you do a good registration, melanoma is more frequent. But of course, a melanoma during pregnancy, it's an operation and that's it. So from that point of view, it is not so much different from the non-pregnant situation, so it's not so important that we missed it. But just from data point of view, melanoma is the most frequent.
And just to add to that very important question, if you rated from the most frequent to the less frequent, you told us about melanoma and breast cancer. After that, what did you say regarding cervical, ovarian cancer, and so on, regarding their incidence? And of course, the other differences based on country, on geographical area, and so on.
Yeah, well, I think so, because you still have countries where there is no screening for cervical cancer. If I think in Eastern Europe countries, sometimes there is no screening. In African countries, there is no cervical cancer screening. So cervical cancer during pregnancy will be much more common in those countries when compared to countries where there is screening. So it will differ a bit from country to country, area to area. Regarding the incidence of the gynae cancers, cervical cancer is about 12-13% of cases. Ovarian cancer also, but then this ovarian cancer figures, it involves also borderlines, which are actually benign tumors. So I think...
but still challenging to make an advice from an expert. So
yeah, of course, yeah. And I think ovarian cancer will be about 5-6% invasive ovarian cancer. But second is also, so what we get breast, but also all the hematological cancers together, they take 20% of the whole group. Yeah.
So, in order to go, let's say, a little bit more on the core of the therapeutic approach, a first fundamental question of even a baseline, let's say, obstetrician gynecologist is how much actually the gestational age alters our therapeutic approach for an early stage cervical cancer, or we may also expand this question to the other type of cancer. I mean, actually, this discrimination between the first trimester and the rest of the pregnancy is, let's say, the key point, or we should think about that differently?
Yeah, I think a bit differently. Of course, but because during the first trimester you can operate, the only thing what you cannot do is chemotherapy. Okay. But I think the cutoff is a bit different for several cancers, but because, for example, 18 weeks for ovarian cancer, as I said, that's the 18-week cutoff is important because you cannot do a debulking or a full staging after 18 weeks. Of course, 18 weeks is also, you can discuss a bit, so, but let's say that's a cutoff. In cervical cancer, what's important always is the pelvic lymph nodes that you want to do. So, and then actually it depends a bit. So, I mean, to do a pelvic lymphadenectomy, you can do that at 18 weeks, but not at 22, 23. So there the cutoff is a bit higher. So it depends a bit on the type of surgery and the gestational age. I think those two actually determine what you can and what you cannot do. And that's a bit different for ovarian cancer and for ovarian cancer. So it is not really it is the gestational age, but it's also the type of surgery.
So it's actually both, the combination of the type of cancer, the indicated treatment, the preoperative findings, and let's say the semester of the pregnancy.
Exactly.
And it might be altered, let's say, a little bit, because if we stick to cervical and ovarian cancer, the limit of the 18 weeks, it's really fundamental, as you already mentioned in your session about giving or not giving chemotherapy.
Yeah,
so it
exactly.
Really other things.
Thank you. And for the next question, what should be our consultation regarding need for chemotherapy in apparently early stage ovarian cancer during pregnancy?
I think we can give the chemotherapy, but I think we should follow the guidelines. So there is no reason that for pregnant women we should give other chemotherapy. So if the guideline says we have to give Taxol carboplatin for 6 cycles, well, we should do that also in pregnant patients. And that is the best guarantee that they will have the same prognosis as non-pregnant patients. So the indication and the type of chemotherapy should not be influenced by the pregnant state. The only exception is with the cisplatin, because cisplatin can give ototoxicity. I'm not so in favor of giving cisplatin, but then the germ cell tumors, then we have to negotiate with the patient. And I think there it depends also a bit on gestational age and the total volume of cisplatin. For example, if you give 3 cycles, the ototoxicity we see in children is also related to the total dose of cisplatin. So if you give 6 cycles of cisplatin of 3, I would not give 6 cycles of cisplatin to a pregnant woman because the child is likely to have severe ototoxicity. But 3, I think it would be fine. So it depends on all these, but that's the only discussion. So for germ cell tumors, but for all the others, I think we can give the standard chemotherapy from the ESGO guidelines.
Very well. I think it's pretty clear, despite the general fear that there was present for chemotherapy, that there should be no fear, and the limit of 18 weeks is a limit in which, apart from that, we can give chemotherapy. However, if we go to the other complementary treatment, the other major complementary treatment, that of radiotherapy. What about radiotherapy generally, should it be an option in pregnancy or should be rather contraindicated because of the profound toxicity for mother and fetus? And may there be any specific cases in which targeted chemotherapy away from the gestational field could be given?
Yeah, I think the question to give radiotherapy or not depends on the location. Where do you want to irradiate, and what is the gestational age? I mean, the higher the gestational age, the closer the pregnancy comes to a field of irradiation. And then it depends, are you going to irradiate a breast or a brain tumor? I mean, this is a big difference if the fetus is there. So all these parameters are needed to be taken into consideration, and then you need to talk to a physicist. And this person will calculate for this patient with this biometry, for this cancer, with this ray that we want to expose, and with this field, and with this gestational age, we estimate that this will be the fetal exposure. And if it's below 100 millisievert, it is supposed to be fine. And so we can, and of course the pelvis we cannot irradiate. So we can do it depending on certain factors, that's important. We now have a recent paper where we looked into the follow-up of these children, and these children do well. So it's a very unique series, because in radiotherapy we have theoretical data from Nagasaki, Hiroshima, Chernobyl, nuclear plant disorders. But that's not a medical field, so our paper was the first time in the biomedical field that we follow the children after antenatal exposure to chemotherapy in the situations that I explained, and these children do well. What we now want to investigate is proton therapy, because proton therapy it's much more focused, and we did some first calculations, and there we already observed that the fetal exposure is 10 times less when compared to conventional radiotherapy. So if we talk to the future, I think it could be that we focus more on proton therapy, and that proton therapy is even more safe than conventional radiotherapy. But also there are options.
Well, really interesting the last conclusion about the proton.
Yeah.
So, for example, even with in cervical cancer,
Yeah.
with IMRT and all these new techniques,
That you cannot do in pregnancy.
you can.
No. The cervix.
You cannot spare the.
No, that's really too close. For example, even to give you an example, rectal cancer is also treated with chemoradiotherapy. You could say, but also rectum carcinoma during pregnancy you cannot irradiate because the uterus is too close to the rectum. So you really need like a distance of 10-15 centimeters. Maybe the size. Suppose you have a metastatic bone lesion in the sacrum. Maybe with proton therapy you could quite safely do that during pregnancy. But when it's the cervix or the rectum, no, that's too close.
Continuing the problematic of Osnat, I'm not really sure if this has been mentioned or investigated, just an idea taking advantage of your expertise. Irradiating the upper abdominal space, let's say for para-aortic node, in a small gestational age, could that be in any sense?
It could be evaluated, yeah. I think it's worthwhile to investigate this and to talk to a physicist and to explain which field you want to irradiate for that gestational age. And I think it might be possible. The problem is that you can
triggering cases. I mean, it's
you have the shielding, right? You have the beam, you got the patient, and then you will with your shield you will avoid that the pregnancy is irradiated. But what happens is there is always this internal scatter. So the radiation goes here, but then in the body it goes everywhere, including to the fetus. So you always have these internal scatter.
Okay. I think the last one is like a question we already asked. So.
Yes, and actually we may summarize. We may make a summary, and I want also to make, let's say, the binding with also the patient's alternative. Actually, the last question would be what should be our recommendation for systematic treatment and supportive medication in the context of cancer during pregnancy. And I want to elaborate a little bit, saying how is actually the patient's perspective to all that, based on your experience and apart from guidelines. Can we really support them efficiently in well-advanced centers? Because that should be a key message. How you treat all that situation, because this is in the core of the new guidelines.
Well, I think it's important to take time for it and to propose some psychological support, actually to talk to the patient and to see where do you need support or not. We also have to say that we see a big difference in women between coping mechanisms. And some women say, listen, I handle it. I see it, I handle it, I've got a good husband and I can handle it. I don't need extra support. And other women, for several reasons, could say, yeah, I need some support. So I think it is to evaluate this, but also to look into the family. I mean, who's around? Is there still a family around? And how big is the family? And how supportive can they be? Because there might be a big family who cannot be supportive. So, I mean, how concrete is this? And I think we have to involve all these parties, explain, and then, yeah, it certainly is feasible. And I think, yeah, sometimes we see that they have less side effects, because you talked about treatment of side effects and supportive treatment. There is always a chemodilution, so that means that we have the impression, although we don't have it in data, that women have less side effects of chemotherapy, and probably because of the chemodilution, that yeah, they have less side effects. So then you need less supportive treatment. So
you have that feeling, that clinical feeling, even if we do not have data to support.
Yeah, but this feeling is shared with all experts who give chemotherapy. They all say the same. We have the impression that our patients, they have less side effects. That is one thing. And then the other thing is that well, from psychological point of view, women get their treatment for 2 patients. So they get some energy from that. They say, well, they are happy that we don't have to interrupt the pregnancy, and they feel the baby kicking in the abdomen and tummy, and then they, okay, that's an extra motivation sometimes for women to continue, and then it's more like, yeah, it's so they are extra motivated. And that brings me to a very important point. Once the pregnancy is over, then disappears, because then the baby is fine, and then women sometimes only start to realize really what happened.
What was the rationale of it?
Yeah, and also about the cancer, but also the chance of a recurrence. Because during pregnancy, it is always like, yeah, okay, I hope I can save the pregnancy, and the focus is really on the pregnancy, and then a bit less on their own health and prognosis. But then there is this delivery, and then, yeah, everything becomes a bit more normal, and then just they start to realize actually that, well, it's about them, and that now the baby is fine. Yeah, they have this chance for recurrence and maybe further treatment and so on and so on. So we need to pay attention for that. That we need to give them this extra support during pregnancy, but we should definitely continue that during the postpartum, and not say, okay, cancer during pregnancy is over, now we go to standard treatment. No, they really need more support also in that case.
That's important. Thank you.
Okay.
Thank you very much for that conversation.
Pleasure is mine.
Really
Happy to support
productive.
ESGO.
And of course, keep going with that project, because I mean it's one of the most innovative and with major clinical impact. And something, let's say as a whole, I mean, it's really nice to conclude that we made a talk of about 20-25 minutes, and the word interruption of pregnancy was, let's say, only the end here once. So that means that we have many possibilities, not in every and all cases, but we have many possibilities.
When we started, so the 20-year celebration is in May, as you saw, but when we started, interruption of pregnancy was the standard. I mean, pregnancies were ended, always, nearly, not always, but nearly always. And it's obvious. I mean, pregnant women cannot eat raw meat, they cannot eat raw vegetables, they cannot drink, they cannot smoke. And then chemotherapy, which is designed to kill rapidly, yeah, that is possible. But I mean, it's so counterintuitive. And initially we had really some objections that medical oncologists said, Frederic, you give the chemotherapy, I don't want to take anything, you know? But then we said, no, but so a lot changed.
Yeah, it's a big progress.
Yeah.
Thank you for all your
Pleasure
Thank
was
you very
mine.
much.
Thank you.
Good luck, and thank you for your all support to ESGO.